So this afternoon's topic is really around fetal alcohol spectrum disorders and co-occurring issues. And again, this is kind of a passion of mine. The reason I got involved in fetal alcohol spectrum disorders over 20 years ago was my son Bill, who was diagnosed with fetal alcohol syndrome when he was 19 years old. I began to identify the difficulties, of course, very early on. He got lots of misdiagnoses along the way, and even after he got the diagnosis, it was hard to convince people that this is really what was causing some of his behaviors. So it's really essential for everybody, for families, and for professionals in every system of care to really understand this. So one of the things that we know, for example, is that we can only get the best outcomes in any setting if we recognize all of the co-occurring issues and if we address them all. In the old days, especially coming from the field of mental health, we would treat one thing at a time. So I remember when people would come in for mental health treatment, if they had a co-occurring substance use disorder, we would tell the person, you have to go and get clean and sober before we will treat you. And if somebody had a co-occurring mental illness and a substance use disorder and went for substance abuse treatment, they were told in order to have treatment here, you cannot have any other treatment, not take any substances, including any medication, including any prescribed medication. We know now that, of course, neither of those approaches worked. Because, for example, if somebody had a major depression and a substance use disorder, if they got clean and sober without the treatment for the depression, then the depression, in a sense, would probably feel worse, and it would really be an incentive to go back and use. So we know that we need to treat them all at the same time. If we don't recognize one of the co-occurring issues that somebody is dealing with, then we're not going to get the best outcomes. And a lot of people talk about co-occurring disorders, and I really expand that, and I talk much more about co-occurring issues. So that includes co-occurring disorders, but it also includes things, as you see here on the slide, like homelessness, a lack of heat, a lack of food, family disruptions, foster care. All of those are co-occurring issues. Being involved in corrections. All of those are co-occurring issues. They're not disorders, but they're issues that affect people that we need to pay attention to and we need to address if we're going to help people be the most successful. If there's a co-occurring FASD with other issues and we miss the co-occurring, and then, as it says, the treatment, we need to modify our treatment. So I'll talk some about some common co-occurring disorders, and I'll talk about some common misdiagnoses, because in either case, we need to understand the FASD. If there's a misdiagnosis, if the behavior looks like FASD or looks like another disorder but really isn't, for example, often it may look like ADHD, and a lot of people with an FASD get diagnosed with ADHD, and some of them absolutely have a co-occurring ADHD, but some don't, and some have just behaviors that look like ADHD, but it's not a true ADHD. And again, if we have the wrong diagnosis, then we're going to provide the wrong treatment and we're going to get the wrong outcome. It's really important to accurately recognize an FASD no matter what else is going on with the person. I mean, that's basically the bottom line, that often a person with an FASD may have co-occurring issues, and even if they do, we need to treat those issues differently, understanding the FASD. And often they may be misdiagnosed because the behaviors may look like something like attention deficit hyperactivity disorder, but if it's not a true attention deficit hyperactivity disorder, we can't treat it the way we would treat a true ADHD. And then again, if we don't recognize the FASD, and this is what's most common, of course, because we know that diagnostic capacity is so limited around the country, actually around the world, in diagnosing an FASD. And if we don't recognize it, then often, since so many individuals with an FASD are very bright and very verbal and can repeat what they need to do but can't operationalize it, then we have much higher expectations for those people. And then what we're doing is setting the person up to fail. And what I see happening a lot is this begins very early on in life. It begins with parenting. So if parents don't recognize that a child may have an FASD, we will often use our typical parenting approach, which is most often a reward and consequence approach. If you finish your homework, then you get to play Xbox. Once you finish your homework, you can go out to play. Whatever it is, once you finish your chores, you can do X, Y, and Z. Once you get ready for bed, you can watch TV. Whatever it is, those are all set up as reward and consequence. And what we know in FASD is that there's damage in the part of the brain that's responsible for abstract thinking in the frontal lobes, so that they don't get that kind of cause and effect, historical time and future time. So they keep not getting the rewards. Then they go to school. They may be in a special education class. I don't think I've ever seen a special ed class, hopefully there are some, that doesn't use some type of reward and consequence approach, a star, sticker, or point system. And these kids often have the lowest number of stars, stickers, or points, but they don't understand why they're not getting the rewards. And often they'll say, but I did what I was supposed to just now. They get into treatment settings, and they don't get their privileges, they don't get their pass, and they don't understand why. My son Bill was in residential treatment for 3.5 years, and he was on level 0 for the entire time. And the staff's view was he's not really motivated for more privileges, and that wasn't the case at all, not at all. So then what happens if you continue to fail, and you don't understand why, then the only real two options are either you are just bad, or people are just mean for no reason. And if people are mean for no reason, that's a little scary, because then you have no control. And if you feel like you're just bad, and this is not conscious, it's kind of subconscious. If your self-image is that you're just bad, then at least there's this piece of sense of control that you've caused this to happen, even though it's negative. And then as they get older, often they will sabotage anything positive because it doesn't fit with their self-image. So we constantly are kind of reinforcing this vicious cycle of feeling bad, setting up systems where they don't achieve success. They don't understand why. It must be that they're bad. We talk a lot about when we find the right motivating factor, they'll do what they need to do. That often doesn't work. And again, must be that they're just bad. Now, up until the DSM-5, which came out in May of 2014, there was nothing in and that's the Diagnostic and Statistical Manual for Mental Disorders. That's the Bible for psychiatry. If you want to treat a mental health disorder, it better be in the DSM. If it's not in the DSM, it doesn't exist. And we've had such trouble really getting mental health to understand the impact of FASD, and part of it is it wasn't in the DSM. In the DSM-5, we do have a diagnostic term in the DSM itself under the umbrella of other specified neurodevelopmental disorder. And as you see here, it has a code, which is a code for psychiatry, 315.8. And in parentheses, you have another code, F88, which is a code for the International Classification of Diseases. Now, I know that a lot of people don't like the DSM. A lot of people aren't using the DSM-5 yet. But HIPAA, has said that once the ICD-10-CM code is released, which is supposed to be in October of this year, then that will be the standard for all diagnosis, which means to me that if you want to get paid for treating a diagnosis, anything, medical or psychiatric, you need an ICD code. The example they give in the DSM-5 for other specified neurodevelopmental disorder is neurodevelopmental disorder associated with prenatal alcohol exposure. So I think that that's a step forward. I think that we really need to think about revisiting diagnostic terminology, and I know that there are some people talking about coming up with diagnostic criteria for neurodevelopmental disorder associated with prenatal alcohol exposure. And I think under that diagnostic term, we could talk about the range in the spectrum. We could talk about fetal alcohol syndrome, partial fetal alcohol syndrome, or PFAS, ARND, or alcohol-related neurodevelopmental disorder, but if we only use those diagnostic terms, they're not in the DSM and they don't have an ICD code. That's my own personal concern. Oops, sorry. So again, we get a sense that most likely, as you see here, there is a pretty significant percentage of people with an FASD who have co-occurring mental health issues, either because of a genetic vulnerability or because of a family history or because of living with this. So there was one study, which is a clinic-based study, that was completed in 1996 called the Secondary Disability Study. Remember, this is just one study, and this is only a study of people who came into a clinic clearly because somebody identified them as having issues. So we don't know that 90% of people with an FASD have mental health problems because we don't know how many people are living in the community with an FASD who don't have mental health problems, but we know there's a significant, that's a pretty significant number. So in this study of 415 people, over 90% had significant mental health problems. So we can really extrapolate that there's going to be a pretty significant percentage in the overall population of those with an FASD. We know that there are a number of mental illnesses that have a really strong genetic vulnerability, like schizophrenia, bipolar disorder, major depression, and ADHD. We also know that those are disorders with significant levels of co-occurring substance use, and often people with these disorders are using substances to self-medicate because these can be really emotionally painful disorders. And we also know that that one of the things that causes people who have a genetic vulnerability to develop a full-blown disorder is the number of stressors somebody experiences in their life and their ability to cope with stressors. And we know that people with an FASD experience incredible stressors often from birth on, and often have really poor coping mechanisms to deal with those stressors. And we know now that there's also a physiological body response in FASD of an over-release of a substance called cortisol under stress, which adds to that. So if they have a genetic vulnerability, they're much more likely to develop the disorder. And unfortunately, they'll come into our system with maybe a diagnosis of major depression, bipolar disorder, schizophrenia, or ADHD, and we'll miss the co-occurring FASD, and we won't provide the right approach. Because what we do is we diagnose people based on their behaviors, and we treat people based on their diagnosis. If somebody has a diagnosis of bipolar disorder, here's the treatment. We may use mood stabilizers. We may use anti-epileptic drugs, which have an effect as mood stabilizers. We may use cognitive behavioral therapy. We know what we're going to do. And then everything that goes on with the person we think is part of the diagnosed illness. So if somebody has a diagnosis, for example, of oppositional defiant disorder, then we think all of their behavior is oppositional behavior. And then we miss really talking about, kind of what's causing this behavior. So I'll give you one quick example, is that a number of years ago, I was doing some training in the field for people in the field who are out providing training in FASD. And it was right around the time of one of the school shootings that occurred in Minnesota. And these people who were very involved in training individuals on FASD were saying, look at this kid's face. Clearly he had fetal alcohol syndrome, and his mother had drug and alcohol problems, so obviously he had fetal alcohol syndrome. And my response to this was, we don't know whether he had fetal alcohol syndrome or not because he was never diagnosed, but whether or not he had fetal alcohol syndrome, it wasn't the fetal alcohol syndrome that caused him to get his grandfather's gun, kill his grandfather, and go to school and kill other people. So not all the behavior is due to a specific illness. Not all, even if somebody had a true oppositional defiant disorder, not all their behavior is necessarily oppositional, but we kind of focus on that. And then we provide our typical treatment approaches. They don't respond. We say that they're not motivated. Then they feel that they must just be bad, and that reinforces that negative self-image, and it just gets into this vicious cycle. And I can't tell you how many times as my son was growing up that I heard and I said, because I was, again, a professional in the field, when we find the right motivating factor, then he will do what he needs to do. And that was just constantly setting him up to fail. So having been in the field, I really struggled with why has it been so difficult for many of us to accept the impact of FASD? And I mean many of us, families and professionals of all levels, and teachers and guidance counselors and therapists in every setting, corrections personnel, child welfare personnel, everywhere. And I really believe that some of the issues are these that are here. That it challenges the basic tenets of everything we've been taught as a parent and as a professional. That often we have been taught that people need to take responsibility for their actions and learn by experiencing the consequences of their actions. That works with a lot of people. That's why we do it. That doesn't tend to work with many people with an FASD. Remember, FASD is a spectrum. From mild disabilities to severe, not everybody with an FASD has the same issues to the same degree. So this might work with some with an FASD, but for most it doesn't because of the brain processing, because of the way the brain is processing information, with this notion of the damage in abstract thinking, with the idea of historical time and future time being damaged. So if we consistently just say, they need to take responsibility for their actions, otherwise they will never learn, that's not necessarily going to be helpful for them. But it's hard to change that view when that's what we have been taught over and over again, and that's what we've learned. And again, it's that maybe we need to do something different. But that's a struggle, and I recognize that is not easy. And there are many families, parents, and other caregivers, especially of adults with an FASD, who have said that they have been told that they need to let their child experience the consequences of their actions, otherwise they'll never learn. And my response to them is that your response needs to be, if I let my child, and that could be an adult child, experience the consequences of his or her actions, he or she will likely end up homeless, in jail, or dead, because that's not how they learn. We also think that people are in control of their behavior, meaning that they can choose to do the right thing when they want to. So, for example, in substance abuse treatment, we talk a lot about relapse as being part of recovery, and we say that a lot. And we know that recovery is not kind of a straight line. We know that people relapse while they're struggling with recovery. However, when somebody's been in treatment 3 or 4 times, and we keep saying relapse is part of recovery, what we are doing is putting the onus on the individual to change. We're saying when they are ready to change, and they make up their mind that they're ready to change, and they really want to maintain sobriety, then we are here to help them, and then our approach will be effective for them. Again, that works for some people, but tends not to work for people with an FASD. Because they really often do want to do the right thing, and they can't do it on their own. And then we think if we do things for them or with them, that we are just enabling in a negative way and fostering dependency. And we think that, and I hear all the time, they have to learn to do this on their own because that's the real world. And my response is, if they are in some kind of services, then we need to support them. If they could do it all on their own, they wouldn't need our support. So we need to, and everybody needs support. So everybody needs to have a sense of dependency. Who are their supports? Who can they count on when they need somebody? That's that sense of support and dependency that we want to build in people. And again, I was often told when Bill was an adult that I was overprotective, overinvolved, enmeshed, enabling, and unwilling to let go. And if I knew then what I know now, I would have said thank you very much for recognizing that. Because I hope everybody, whether it's a parent or a professional in any field, is enabling the people they're working with, because I hope they're enabling them to be successful with whatever it takes. From my point of view, that's the goal. Also, we have our own biases. We have our own biases about people's behaviors. We have our own biases about women drinking during pregnancy. Some people think that this is willful, purposeful behavior. I have never in 40 years met a woman who said the reason I drank during pregnancy was because I wanted to give birth to a child with fetal alcohol syndrome. But there's still so much stigma that we have to fight against here. But the people have their biases, and we need to recognize that. And again, recognizing FASD may challenge some of those values and biases that we've had. It also may bring up issues in our own lives. I've done training in treatment centers where staff will begin to talk about either they're thinking that maybe they have an FASD because of their family history, or that they have children with an FASD. And some people don't want to deal with this. You know, maybe there are issues in their own lives, and that's why they don't really want to address FASD at all. And maybe that's part of the struggle we have in getting, you know, funding for this, is that people don't want to address it. It also means if we recognize FASD, we have to do something different. And that's tough. It's easier to do what we've learned over and over again, you know, and just keep doing the same thing. And again, if we say we haven't found the right motivating factor yet, or this person is not ready for change, then it's much easier to say it's up to them. It's not up to us. So if they fail an approach, it's because they're not ready, they're not trying, they're not motivated, they're non-compliant, rather than maybe we need to do something different. And I recognize that these are all challenges, and that these really get in the way of addressing FASD, which is why we really do need to talk more about it. And again, because of the brain processing issues, then they often don't learn this way. So the natural consequences, so for an adult, the natural consequence of not paying your rent is that you get evicted, then you will learn to save your money to pay your rent. That works with some people. With many people with an FASD, all it does is set them up to be repeatedly homeless, because the concept of I have my money today, but I have to save it for next week, the week after, or the week after that is an abstract concept. And again, that area of the brain is impacted by prenatal alcohol. So we don't want to put the person at risk, especially of ending up homeless, in jail, or dead. So we need to recognize again that often natural consequences are not going to be terribly effective. Now, this does not mean that nobody with an FASD should ever get consequences, and we can talk more about that. But again, the basis of all of our approaches is this approach of reward and consequence. So we need to really rethink the concepts of dependency and enabling as negative and start seeing them as positive. For the person with, I always use the example, let's say there's an adult who needs supplementary security income. For some people, we could give them the application and just tell them you have to complete the application, go to the Social Security office, have your appointment, and submit your application. And then if you get a letter in the mail that denies it, then you have to write an appeal if you want. But for the person with an FASD, typically we may need to sit down with them, fill out the application together, call the Social Security office, make the appointment, and arrange not only to just take the person to the appointment, but if it's okay with the individual, to sit in the appointment with them. So that if the Social Security officer says, now you have other income, you have regular income every month, don't you? And the person with an FASD says, yeah, because they want to please the Social Security officer and because they're not really sure what he or she is asking, then the person who's in the appointment can say, can explain that and say, now what she's asking is, do you have money that you get every month? No, I don't get any money every month. Again, clarifying that. That might be what the person needs in order to be successful. And again, that's what we want to ask. What does this person need in order to be successful? And how do we get that for them? So if they have an FASD, if they do have an FASD and there are co-occurring disorders, this is the common view that we have, is that we'll just, again, treat them all together, but we really treat disorders in parallel. When it comes to FASD, though, this is really not the appropriate approach. When it comes to FASD, the appropriate approach is really whatever is going on with the person. So if they're homeless, if they have a learning disability, if they're a child, if they're in foster care, in a foster home, if they have a substance use disorder, if they have bipolar disorder, whatever is happening with that person, if they have an FASD, our approach to that person needs to be modified, because the FASD tells us that their brain is processing information differently. And so here's another example. If they have had a suicide attempt, and I'll talk a little bit about that if we have time, if they have a sexually transmitted infection, again, if they have an FASD, we approach that really differently. So whatever's going on with the person, if they also have an FASD, we need to modify our approach. We don't need to create a lot of new approaches. We just need to really modify what we have, recognizing how the brain is working. So here are some likely co-occurring disorders. I talked about the genetic vulnerability for the first four. So again, they may have a true co-occurring attention deficit hyperactivity disorder, or schizophrenia, or depression, or bipolar disorder. They may have a true co-occurring substance use disorder, because for some with a substance use disorder, there is a genetic vulnerability. For some, it's family traditions and family loyalties. And as a therapist, I can't tell you how many family genograms, family diagrams I did over the years where we identified 4, 5, or 6 generations of alcohol use in the family. Not alcoholism necessarily, but just alcohol use. It was part of the family tradition. That was before I ever heard of FAS. Also because of peer pressure, substance use disorders, and also, as my son Bill taught me, that living with a hidden disability that nobody recognizes, being told over and over and over and over again from everybody, you are bright, you can do this, you're just not trying hard enough, you're lazy, you're unmotivated, when really they are trying and they can't do it. That's very, very emotionally painful. And one of the ways that some people can deal with that emotional pain is by using substances. So again, for many different reasons, we may see a co-occurring substance use disorder with an FASD, but our treatment for the substance use disorder needs to be modified. We can't use motivational interviewing the way it was developed. We can't just do verbal individual therapy and group. It's not an AA and NA. It's just not going to be effective. Other likely co-occurring disorders, many of them have sensory issues, significant sensory issues to light, sound, temperature, texture, taste. As children especially, but also as adolescents and adults, we see it. So bright lights, loud sounds, bright colors, certain fabrics that they can't tolerate, things like tags that are sewn on the inside of clothing often can drive them crazy. And tagless clothing is great for people with an FASD. They may have a co-occurring reactive attachment disorder, especially if they've been moved around a lot. But what you will also see is that that might also be a misdiagnosis. Separation anxiety disorder, especially, again, if they've been picked up and moved from place to place to place, they may be afraid to leave home because they may not have a place to come home to. Many of them have a high risk for abuse and trauma and may experience a co-occurring post-traumatic stress disorder. And even though we are in an era of talking about trauma-informed care, the experts in the field of trauma basically are saying this is how you treat trauma. It doesn't really matter what else is going on with the person, but it does. We have to know how their brain is working in order to say how are we going to treat the trauma. They may have a traumatic brain injury on top of the FASD, because as children and adolescents, they may have balance problems and fall and hit their head, not recognize danger, ride their bike into a street, get hit by a car, get into fights, get beaten about the head, and suffer a blunt head trauma on top of the FASD. They're at risk for borderline personality disorder as adults because one of the risk factors is repeated trauma, and they're 5 to 60 times more likely to have certain medical disorders. So any infant born with a cleft lip or palate or born with a seizure disorder, somebody should be asking about prenatal alcohol exposure. It's not the only cause, but it is one significant cause. Anyone with scoliosis, anyone who has certain atrial or ventral heart abnormalities, we should just be investigating, could this be due to prenatal exposure? not as a matter of blame or shame or guilt, but as a matter of how do we help this individual and family best. And I want to give you a quick example, and if any of you have heard me, I apologize because I've used this before, but why, if they do have a co-occurring reactive attachment disorder, why do we need to understand whether they have an FASD? So I have a colleague who has a couple of children with an FASD. I was at their house one Sunday. One of their sons had a friend over. After dinner, he said to his father, "Dad, can my friend stay over tonight?" And his father said, "No, he can't stay over tonight." "Why not?" And his father was calmly explaining why he couldn't stay over, and sitting in an easy chair, and this youngster kind of climbed onto his father's lap, grabbed his father's shirt with both hands, and started shaking his father's shirt, saying, "Why can't he stay over?" Getting more and more and more agitated. And this went on for quite a while. Every once in a while, the father would say, "Don't rip my shirt," and then went back to being calm. And the youngster was getting more and more agitated. Finally, his father sent his son to his room, and he calmly explained all the reasons. You have school tomorrow, you have to get ready for school, you still have homework to do. All the rational reasons, of course, didn't matter. And then finally he sent his son to his room, sent the friend home, and I said, I'm not sure that was the best approach, because he has no idea how much is it okay to grab your shirt and how much is it not okay, and it just escalates him. And he said, I brought him to an expert in reactive attachment disorder, and she said, this is how he attaches, and I have to let him do that. And I said, but not if he has an FASD. The best thing is don't let him grab your shirt at all. And what I heard afterwards was, a couple of months later, was that he stopped letting his son grab his shirt, and he de-escalated a whole lot quicker. So again, even if they have one of these co-occurring disorders, we need to take into account the FASD. In addition to the co-occurring disorders, of course, there are a lot of misdiagnoses. Some of them look exactly like the co-occurring disorders. So we wonder, does it matter? If it looks like an oppositional disorder, shouldn't we treat it as an oppositional disorder? If it looks like ADHD, shouldn't we treat it as ADHD? And one of the things that my son Bill taught me was that I had to be visual. I couldn't just be verbal. I had an auditory. I needed to use more senses. So he really taught me to do charts. And I've become much more visual, and I really like charts. So this is one of them. And what you see here is that if you look at the first row here, it's the behavior. So if you look at somebody with a true oppositional disorder, one with a true attention deficit hyperactivity disorder, and one with a true FASD, they all have exactly the same behavior. You've given them 3 instructions, they haven't followed through. Behavior is exactly the same. You can't tell what's going on. And unfortunately, what we typically do is go from the behavior to the intervention for the behavior. You say to a child, go upstairs, brush your teeth, get in your pajamas, get ready for bed. You go up to their room a half hour later, they're fooling around, they're playing, they haven't brushed their teeth, they haven't gotten in their pajamas, they're not in bed. You didn't get in bed on time. Tomorrow you're going to lose Xbox time, or you're going to have to go to bed early, or whatever consequence we come up with. So we go from behavior to consequence. If it's a treatment setting and you say, go to your room, get your journal, be back for group in 5 minutes, they don't show up for group, they lose their pass for the weekend because they didn't show up in group. So we go from behavior to consequence for the behavior. And we don't stop at this middle row, which is the most important for everybody, not just those with an FASD, which is what's causing the behavior. Because if we don't know what's causing the behavior, we can't come up with the right response to the behavior. And this is true for everybody. And we just don't do it because it's easier to say, here's the behavior, here's the consequence for the behavior, or the reward for the behavior, whichever it is, and not think about what's causing it. Because if you have to think about what's causing the behavior, then you have to modify the approach depending on what's causing the behavior. And you can see on this chart that what's causing the behavior is very different in these individuals, these 3 individuals, so that the response needs to be really different. And a really good example that for me drives this home as to why it's important to know the cause of the behavior is that in a former job that I had, I wrote courses on youth and violence, And in those courses, what I found, in preparing for those courses, what I found was that there were a number of individuals with violent behavior where they found tumors in certain structures of the brain, where when those tumors were removed, the violent behavior stopped. So for those individuals, no matter how much they were consequenced for their violent behavior, it was never going to change their behavior because the behavior was due to the tumor in this certain area in the structure of the brain. Again, what's causing the behavior is a very, very important question to ask. And then I have a couple of other charts here. And some of it you can't read because of the footer on the slide. I apologize for that. But it's really important to know what's causing a behavior. So this third chart, for example, they all have acting out antisocial behavior. The individual with an adolescent bipolar disorder, because that's how a mania is often demonstrated in adolescence. An adolescent depression sometimes is an agitated depression where we see acting out antisocial behavior. And in FASD, we may see acting out antisocial behavior, especially for those with an FASD who have gravitated to the negative peer groups and are modeling that behavior, the gangs, the others, and then they model the behavior of those around them. So again, the behavior may be exactly the same, what's causing the behavior is different, and the approach needs to be different. Because if it's an adolescent bipolar disorder and you think it's a depression and you give them an antidepressant, they are very likely to then develop a hypomania. And when you stop the antidepressant, the mania won't go away. If it's an FASD, the antidepressant isn't going to help with the FASD, with the reason they have the acting out antisocial behavior. So again, what's causing the behavior is a really important question always to ask. Other possible misdiagnoses are autism and high-functioning autism, because it looks very much like autism in some ways in terms of social functioning, the ability to read social cues and know how to respond, and especially high-functioning autism, which used to be called Asperger's syndrome. And in the DSM-5, it's not Asperger's syndrome anymore. It's now high-functioning autism. As I said, they may have a misdiagnosis of reactive attachment disorder because they have attachment issues, but not a true disorder. A traumatic brain injury, and as adults they're often misdiagnosed with antisocial or borderline personality disorder because of their behaviors. And I know I need to go through this pretty quickly. So if you want to, you can look at the video of this webinar when NOFAS posts it, because I have these slides on similarities between FASD and autism, and there are definitely some similarities, but there are some striking differences. And one of the differences that I think is really important is that really in true autism, there is difficulty in both expressive and receptive language. And in FASD, there's much more difficulty in receptive, verbal receptive language than expressive language, which gets them into trouble because they can talk a good game, but they can't follow through. Also, we don't see the kind of hand flapping and toe walking in FASD that we typically see in true autism. And in some communities where physicians don't want to talk about alcohol use with women, they're much more likely to diagnose a child with autism than with an FASD because they don't want to address the alcohol use. So there are some people being diagnosed with autism where it's a misdiagnosis because, again, they both have difficulty reading social cues and knowing how to respond. But if you look carefully, you know, there are these real differences as well. And then I just wanted to put a little piece in suicide risk, because two things that we have difficulty talking about are sex and death. And both of those are really important things to talk about when it comes to individuals with an FASD. They are at higher risk for suicide and for suicide attempts. And there are 16 risk factors that the Surgeon General came up with for suicide. And if you look at these first 8, people with an FASD most of them meet all of these 8 risk factors. So if we want to look at a high-risk population for suicide, we really need to be talking about people with an FASD. And even the second 8 of the 16, they often meet a lot of those risk factors as well. But the way we deal with death and the way we deal with suicide can be problematic if somebody has an FASD, because if we begin to talk about, well, this person is at peace now, or she's with God, then, or God wanted him with her, or her with him, either way, then this person with an FASD may think, well, you know, I want to be with God, so if I kill myself, then I'll be with God. Or I want to be at peace, so if I kill myself, I'll be at peace. And we see communities where there's a rash of suicide, and I'm pretty sure that at least some of those individuals are individuals with an FASD. They see the whole community being very upset. If I kill myself, then I'll see that people care about me because they'll be really upset. Because they don't think through to the consequence, but I won't be here to see that. That's the problem. They don't think that far ahead. This is just some studies that were pulled together out at the University of Washington, and it's pretty striking. So if you look at, in the U.S., about 5% overall of individuals attempting suicide, and this one study of those with an FASD, almost 5 times that percentage attempted suicide. And the 2 bars on the right are from the Parent-Child Assistance Program, which is, you know, this wonderful program in Washington that works with women at highest risk, and a number of other states are using it, and provinces. Women at highest risk of giving birth to a child with an FASD. So the last column here are the women in the program who have not had an FASD themselves, but most of them do have a child with an FASD. 33% of those women had attempted suicide. And the column to the left of that are the women in the program who themselves had an FASD and also had a child with an FASD, and that's almost 9 times the national average had attempted suicide. And the way we assess suicide risk needs to be modified, because we can't look at suicide risk by looking at lethality of attempt. There's no correlation for those with an FASD. So we have to change our approach to evaluating suicide risk and also to intervention. And then we also don't talk a lot about FASD and sexually transmitted infections, but I think that people with an FASD are at high risk for HIV and sexually transmitted infections, because the idea of not only knowing safe sex techniques, but pulling them out when you need them and being able to negotiate safe sex at the time of having sex is really hard. And so that puts them at risk. And then you have people where, because of the damage in the amygdala of the brain that's responsible for recognizing fear and danger, they don't recognize dangerous people or dangerous situations, and whoever they meet for the first time is often their best friend or their new boyfriend or girlfriend. So again, I think they're at high risk, and I think how we approach sex education and prevention of sexually transmitted infections and HIV needs to be modified if the person has an FASD. But we need to begin to talk much more about FASD and sex than we do. So again, and then how you treat it. We need to review the treatment over and over again, one step at a time, the importance of continuing treatment even if you feel okay. Again, how we approach it needs to be different. So if we recognize an FASD, it really informs what we do. So we can't just use verbal approaches. We can't just tell people what to do verbally and expect that they're going to follow through. We can't give them 3 or 4 directions at once verbally and expect that they're going to be able to do it, because there's damage in the working memory of the brain. We have to break it down to one step at a time. We have to use more senses. The more senses we use, the better. They often do better with computer-generated programs because they're visual, tactile, and auditory. They often do well with role-playing because it uses more senses. We know that across the IQ span, even when they're very bright, they tend to be very literal in their thinking. So we have to be careful about what we say. If you get mad at somebody with an FASD and you say, go take a hike, don't be surprised if they disappear for 8 hours, They are very literal often in what they hear, and they will do exactly what they are told to do, word for word. And then don't expect the person's going to be able to think about their life, think about what goes on, like in a therapy group. The idea is that people talk in group, and then you think about that, and you think about how that impacts you, and what in your life you may want to change. That is very, very difficult for people with an FASD. The work all needs to be done together. So one step, one rule at a time, lots of repetition, not because they're not paying attention, but because of the damage in working memory. And then always check for true understanding. So never just say, do you understand, or do you have any questions? But say, if you're going over rules, what does that rule mean? How would you follow that rule? I've had people say, well, if they don't have a lot of insight, then they don't benefit from therapy. That's not true at all. But supportive psychotherapy can be really useful. Insight-oriented psychotherapy might not be the use, but not be the best. Classic, and I say classic because cognitive behavioral therapy can be modified. But when it's just talk therapy, and the idea is pointing out discrepancies, in their view of themselves in the world and other people's view, and thinking that they're then going to be able to take that in and think about it on their own, that's what needs to be modified. Motivational interviewing can be modified, but it needs to be all work that's done together, very concrete, very visual, not just talk. We need to modify the approach to recognizing suicide risk. Don't just look at, again, lethality of attempt as a measure of intent to die, because that's disrupted in FASD often. Don't just have suicide contracts, but you may talk with the person about, anytime you feel that way, you call me. That could be really helpful, and we'll talk. And then modify the approach for sexually transmitted infections. If they're not following through, don't take that as a lack of motivation. They do really well often, as many of us do, with like a one-to-one buddy, a mentor, a role model, a buddy, which could be, again, as you see here, it could be a family, it could be a friend, it could be a professional, it could be a church person or another organization. In substance abuse treatment, we're really seeing more and more recovery coaches, which could be wonderful aids for people with an FASD who are in substance use treatment. Helping get them to their appointments. I've talked about, if the person has a cell phone and is missing a lot of appointments, then program into their cell phone with them, not when their appointment is, but when they have to leave for their appointment, because that's recognizing some difficulty in a sense of time. So they may actually know they have a 3 o'clock appointment and leave at 3 o'clock and be late. And if you ask them when's your appointment, they may say tomorrow at 2 o'clock, but the next day at 1:30 or 1 o'clock, they can't pull that out and remember it. So we may want to send them a text reminder, as long as that's okay with them, just as a way to help them. And my approach is always a positive one. If there's so much going on in your life, how can I help you be successful? Move more towards a positive reinforcement system, which is talking about strengths and abilities, catch them at doing something. You didn't get into a fight today. That was great. You ask them for help with something, and then you say, I really appreciate that help. Thank you so much. So just taking the positive. And I remember a parent who was also a professional who came to a training, and after the next day I got an email from her, and she had an adolescent son with an FASD, very angry, very sullen, didn't want to spend any time with the family. And she said that night she went home and she said to him, I really just want to thank you so much for all the help you've been giving your younger brother. I really appreciate that. And then she said for the first time in months he smiled. He hung out with the family. He was pleasant that night. Now, that probably won't work all the time, but it did work that day. Again, sometimes the positives are really helpful. We want to, again, consider the possibility of misdiagnosis. We want to always utilize person-first language. Nobody is FAS. Nobody, from my point, this is my personal point of view, nobody is a substance abusing woman or a substance abusing man. Somebody may be a person with a substance use disorder. Nobody is a schizophrenic, a bipolar, or a borderline. A young man with FAS one time said, I want people to know that FAS is what I have, it's not who I am. And if we look at the person as their problem, then that becomes their identity, and it's not their identity. It's never who they are. So nobody really is an ex-con. Somebody might have been in jail. Nobody is an oppositional kid. Somebody may have oppositional behavior, a person with an oppositional behavior. And then we want to use a true strength-based approach. So we need to identify people's strengths and abilities. And again, what I see is we tell people a lot what they do wrong. And we're focused so much on changing negative behavior. And what we have to do, maybe instead, or in addition at least, is focus on positive behavior. What they do right, what they do well, what do they like to do, what are they good with. And I can tell you that many people, when we started telling them what they're doing well or asking them what they do well, many people won't have an idea because they've never heard that before. So we really want to tell them what they do well, what they're good at. And I think every meeting in every place, I don't care what it is, with kids, adolescents, or adults, should always start by everybody in the room going around and identifying the strengths in the individual, in the family, in the providers, and in the community. We want to modify our approaches. Anytime you start a sentence with if or when, you're setting up a reward and consequence. And we want to try to stay away from that. Because again, for individuals that have difficulty with a sense of historical time and future time, you're just setting them up to fail. The other thing is we tell people a lot what they can't do and what they can't say. You can't hit people. You can't curse like that. You can't curse in school. And unfortunately, what we don't do is tell them what they can do instead. We don't give them an alternative. And we should never be surprised if they keep doing the same thing if we don't give them the alternative. So anytime you need to say to somebody, you can't say this or you can't do this, you need to tell them what they can do or say instead. And again, another example was a young man who went to school. When he got mad, he would curse at the teachers and his peers using very offensive language. The school would punish him and say, you cannot use that language in school. And I said, if you're going to tell him he can't use that language in school, you have to tell him what he can do instead. You can't curse like that, but this is what you can say when you're mad. You can't hit people, but this is what you can do when you're frustrated. So whenever we need to tell someone you can't, you need to tell them what they can do instead. So we want people to succeed. We want to ask, what does this person need in order to be successful? How do we get it for them? If we can encourage positive outcomes for the individual, we are going to see positive outcomes for our agencies and systems. We want to foster interdependence. We want to remember that FASD is about people. It affects the lives of individuals, families, and entire communities. My son would say the most important thing in people who worked with him were people who really cared and not people who he said were in it for a paycheck. And what I have found is people with an FASD are incredibly intuitive and can pick up in a hot second who likes them, who really cares about them, and who is just in it for a paycheck. People with FASD and their families have great potential, but when things are going wrong, anything positive that's ever happened goes out the window. So we really have to remember, especially when things aren't going well, what has been accomplished. So here's an example. Here's my son Bill when he was 14 years old, and he's in the stocks. We went to Universal Studios, but here he is in the stocks. It was because of his behavior. And here he is 13 years later, and he's still in the stocks. So sometimes it feels like nothing has changed. That's when we need to step back and say, but look at what has been accomplished. I have seen such incredible growth in individuals with an FASD over the years. But sometimes we lose sight of that when we're only focused on their behavior for the moment. And always remember that addressing FASD can literally be a matter of life or death. And there are people with an FASD who have died over the years because we haven't recognized it. We can save people's lives if we begin to recognize the FASD. So I really thank you. I have some resources here. And I'm sure that many of you are familiar with all of these. I thank NOFAS for allowing me to do this. I thank the FASD, the SAMHSA FASD Center for Excellence for pulling this together, because I think that collaboration is just so important. So thank you, and Andy, I'm going to turn it over to you, and I know we have just a couple of minutes left.
All right, thank you very much, Dan. That was a great presentation. A lot of really useful information there, and thank you very much again for that. We do have several questions actually, and I know we're basically right at 3 o'clock, but we're able to go over time a bit if people would like to stick on to hear some answers to some of the questions that people have come in with. And if you have additional questions, Dan is willing to have those emailed to him. Somebody asked, is there an optimum age for diagnosis?
Yeah, the optimum age for diagnosis is birth, uh, because we do know that the earlier we diagnose this, the better the long-term outcomes. Because then we recognize this is an individual who has a disability, and we need to modify what we do with them. So that's the optimal time to diagnose. This is almost never diagnosed at birth. If they have the facial features of FAS, the optimal time really to see those features is probably between, somewhere about 1 or 2 years old to about 8 years old. That's when they're clearest. But remember, the majority of those with an FASD don't have the facial features of FAS. So again, it's a great question, and the earlier we diagnose it, the better.
Thank you. And sort of related to that, for example, a child of 14 years old, if they've been diagnosed with an FASD, how much can a change in their environment or their social situation reverse or change the negative influences in their life?
That's another great question. I think it can change dramatically. If we can begin to, again, recognize, say, the 14-year-old. So there are the adolescent issues also, and some of them are, we have to help them work through and get through adolescence. But, for example, if we can teach them, for example, like with my son, I'll use him as an example again, is that for many people with an FASD, although they have a great sense of humor, they can be really very funny. They absolutely cannot tell if somebody's joking with them or not, because the area of the brain responsible for laughter is in one area of the brain, in the basal ganglia, but processing humor is an area in the frontal lobes of the brain that's damaged by alcohol. So they'll laugh along with others and then think the person is out to get them or hates them. If we can teach them that because of the way their brain works, and again, the damage due to alcohol to the brain does not have anything to do with intelligence. We have to get that across. That people can be incredibly bright and still have damage in the brain. It just means certain structures aren't working the way they should. So if we can teach him or her that because of the way their brain works, they're not sure if somebody's joking around or not, so they need to check it out before they respond. If we can teach them that because of the way their brain works, another area of their brain, that trying to remember 3 or 4 verbal instructions is kind of going to be really frustrating and has nothing to do with how hard they're trying. So that teaching them that everything should be written down, have a checklist where it's reviewed regularly, where people, where they can see where it is and they can consistently check it off. So those kinds of things I think can be really helpful in helping them be successful. The other thing that we can do for the adolescent is begin to talk about what do they like to do, what do they do well, and one of my favorite sayings is we need to find something that the person likes to do and does well that's safe and legal, and arrange for them to do that regardless of their behavior and build on that. Don't use it as a reward for good behavior, take it away for bad behavior, because remember then it's setting them up to fail again, but we want to build their self-esteem and competence. And so if we begin to focus on strengths and abilities, if we begin to ask them to help, for an adolescent, if you tell an adolescent to do something, chances are they're not going to do it. With these adolescents, often if you ask them to do exactly the same thing, they will do it because they really want to be helpful. So I think there's a huge amount that we can do to kind of reverse some of the early, negative experiences.
Great, thank you. Somebody was asking about, are there strategies for helping a young person or a young man with FASD to understand that that they should not be binge drinking or maybe drinking at all, drinking socially?
Yeah. Again, it's great. Another great question. It really is a process of talking about what it does and that how their brain is structured, and they may have this tendency for alcohol to have more of an effect on their brain than it may have for somebody else, and impair their judgment more. And the areas of the brain, again, that are responsible for judgment are often impaired. So it can put them at higher risk. And really what we want them to do is be safe. I mean, that's our goal, is to ensure that they are safe. And that drinking may cause more problems for them, and point out what you've seen if they have been drinking, and talk with them about, what might help them. Why are they drinking? I mean, there's one of the motivational intervening strategies that talks about what are the good things about a behavior and what are the less good things, and in a sense using some of that with, what is it about drinking that you really like, and what are the things that are problematic with drinking? What gets you into trouble, or what are the problems when you drink? And then what we want to do is really, and we want to write those down, and we want to review them and not do it all at once, and really talk with them about the idea is getting those less good things to outweigh the good things, and then talk about how they can get those good things in a better way. So what could we do to help you get those things? I feel more comfortable, I have my friends, and I'm relaxed. Well, how can you be more relaxed and be with your friends without drinking? And some of it might also be connecting them with more positive peers. So if it's somebody, say, who really likes to draw, likes art or something else, is there an art program we may get them hooked up with where there isn't a lot of drinking? And we don't want them to be in the environment where they're surrounded by people drinking, because then, of course, they're going to start again because they want to be like everybody else. So I think it's a process of kind of talking, and again, it's approaching it from a really caring, supportive stance. I want to help you feel safe. I feel better when I know that you are safe, and when you've been out drinking, it hasn't been safe, and I really worry. So what could we do about that?
Great, thank you. And somebody was asking, what are your thoughts on RAD and PTSD developing because FASD was not recognized, and an approach like a teaching approach or treatment approach may have caused trauma?
I think that happens, yes. I definitely think that happens. I think that's why sometimes they're misdiagnosed. And I think that those early experiences, they do cause trauma. Absolutely. Again, it's not like, oh, they've caused a trauma, there's nothing we can do. We never want to feel that way, and I don't think that's true. But recognizing the trauma that they've gone through, I think is really, really important. I've been doing a lot of work with some substance abuse treatment centers, and I think talking with the people in the substance abuse treatment centers about their experiences and validating their experiences and their feelings about it, I think is important. So validating an individual, let's say there's an individual with an FASD where they've gone through this school setting, where they've gone through the reward and consequence approach, and they haven't done well at all, that can be real. That's painful, and we need, what I mean. I don't know if I'm clear, but we need to validate it. When my son got into middle school, he said, "Dad, every day I walk into school, I feel stupid." Well, that's pretty painful. You can't do that very often. You either have to get thrown out of school or cut, because it's way too painful to do that. So I think that some of those early things can absolutely cause trauma. And again, one of the things we need to do is recognize it, and also help them see those experiences as events in their life, but not defining their life. And that's really key. So when somebody has experienced trauma, that's an event in their life that we really have to pay attention to, but that doesn't define their entire life. And sometimes we get caught up in that. And we have to move toward, and then again, when we begin to build on their strengths and abilities and talk about their strengths and abilities, then I think we're moving more towards that's an event in their life that we need to recognize the impact, but it does not have to define their entire life from then on.
Great, thank you. Another question is, if a patient presents at a clinic and has a previous diagnosis of autism or ADHD, for example, what do you think about encouraging the family to stick with that diagnosis, since there may be more funding available to assist them with those disorders, and
That's been
supplement the interventions to address FASD?
right. That's been a huge issue, and not an easy one to answer. Because I remember doing a training for psychiatrists who said, you know, we sometimes we see this and we know it's FASD, but if I diagnose an FASD, they get nothing. The family gets nothing. If I diagnose ADHD or I diagnose autism, then they can qualify for services. And it's a real struggle, because that might be okay for that person working with the individual, but then they get transferred to somebody else. Somebody picks up this chart and sees a diagnosis of ADHD and treats ADHD. And if it's not a true ADHD, the treatment's going to be wrong. And the same is true with autism, because in true autism, one of the treatments that often works well is the token economy kind of approach. And that's doesn't typically work well in FASD. So I think, but I understand it's like, we want to get you services. So up until this point, I can absolutely identify why some people and some families would prefer diagnosis of ADHD or autism, because then they can get services. I am really hoping that if we can start using the DSM-5 and start using that terminology, that we can start then they can get services for an accurate diagnosis. Because my concern about the misdiagnosis is that in the long run, they're not getting the right interventions.
Great.
So I wish I could say, I mean, yeah, the ideal would be that if they feel that it's an FASD, if there's they can diagnose an FASD, that they would get services for that. I know we're not there yet, but I think that's where we're moving, and that's where we have to move.
Thank you. Another question was, are you familiar with TBRI therapy and whether that's effective with individuals with an FASD?
TBRI. No, I'm not sure what that stands for. I'll have to check into that.
All right. And then another question is, are normal or normed suicide assessments beneficial with people with FASD?
I think that's where the problem comes in, because the typical suicide assessments, as I said, in the overall population, there is a direct correlation, for example, between lethality of attempt and intent to die. So if somebody says, I tried to kill myself last night by shooting myself but the gun jammed, we know this is somebody who really needs to be hospitalized while we're dealing with the issues. If somebody says, I tried to kill myself last night, I took 4 Tylenol with a glass of water, then we have to deal with the issues, but it's not a serious suicide attempt, and it's not somebody who needs to be hospitalized. But what's been found in FASD is that there is no direct correlation there. So we have to be careful about evaluating kind of intent to die. That's one thing. The other is we ask things about, we ask more general questions in suicide assessments, like, what do you see in the future? And again, that's too abstract. We have to be much more literal. So again, we need to modify some of the assessment. So, what are you going to do today? What are you going to do tomorrow? And some of the, Natalie Novick-Brown out at the University of Washington and some others have done some really good work in some of the strategies, like, of course we want to remove lethal attempts. We want to build social supports for the individual. We want, as I said, we want to be really concrete, like saying, anytime you feel this way, you call me, in terms of the intervention piece. But even in the assessment piece, we want to assess things like, we want to assess what are their supports, because everybody needs supports. What, if when they feel this way, what can they do? Because we care about them, because we are worried about them. So again, I think that we have to look at the assessment and say, what do we need to modify for somebody who is very literal in their thinking? And it's not just those with an FASD who are literal in their thinking. There are others who are literal in their thinking also because of damage in the frontal lobes, where we need to modify that. Again, another really important question. I appreciate all of the questions that have been asked.
Great, thank you. Just time for a couple more questions. One person was asking to clarify when you were talking about FASD and IQ. This person is asking for clarification on, is it the case that people with an FASD can have a normal or even high IQ?
Yes. Yes, there have been people identified with an FASD with an IQ basically in the genius level, as well as a very low IQ. It used to be thought at the beginning, people thought that this was only, everybody with an FASD had mental retardation, or even everybody with FAS had mental retardation, and that's really not the case. So absolutely, people with an FASD can have normal, average, or above average IQ. It may be in the average range, it may be in the low average range, it may be in the high average range. And the problem is those who have a higher IQ tend to have more difficulty because we expect more of them. But another really good question.
Okay, great, thank you. And I think this will be our last question. This is a pretty good question here. Gets to a lot of the issues we've been talking about. So somebody was asking, if you develop a very caring relationship and bond with a person with FASD and then have to leave or not part of their lives anymore, how do you handle the separation? How can you make it that easier for them?
That's another great question, and that's really tough. And many people with FASD have gone through this many times with people coming and going. And again, the protection at that point, the protective factor is to not bond with anybody. That's why they look also often like they have a reactive attachment disorder if they've gone through all these people many times. So I think that one of the things is to prepare them early and often when that's going to happen. We don't want to spring it on somebody. That would really be the worst thing because that increases anxiety even more. We want to talk with them about it. We want to talk with them why and reassure them. We want to talk with them about, how much we really still care about them. And my point is, and it really depends on, what the relationship is, what the connection has been. Sometimes with professionals, for example, who move on, who've worked with somebody for a while, they just leave, and the message that people get, the feeling, is that nobody really cares about them, out of sight, out of mind, because they never hear from them again. Or a person who has been in a setting for a while and then discharged and never hears from that setting again. Well, they didn't really care about me because, nobody really cares. And I used to do training where I would tell people, especially in long-term settings, after people are discharged, somebody should be calling them every few minutes, every few weeks, not every few minutes, every few weeks to see how they're doing. And it could be a 2 or 3 minute phone call. Hi, we were just thinking about you and wondering how you're doing. Because you want to let people know that there really are people who care about them. Now, having been a therapist in residential treatment, I always knew what was going on with all of the individuals I worked with after they left the agency and after I left the agency, but they didn't know that because at that time it was thought that that would mean that I was over-involved and fostering dependency, and all they would do would want to come back, and that's not been my experience. My experience is it really is important to let people know that there are people who care about them. And also, when somebody is leaving, if somebody's taking their place, the best thing is a warm handoff. But also, if you have this is who's going to, take my place, or, they're identifying somebody, and, if you're not comfortable with that person, here's who you can talk with about it, and make that connection. Make some connection whenever possible. It's not always possible. But those are things I think are really important is, yes, people come in and out of our lives all the time, but for these people, many of them, their experience has been that, once they leave or a person leaves, that really nobody really cares about them. And we really want to convey the idea that, yes, even when people are not with them, they really care about them. So that's, I think, an important thing to get across. And also point out what they've been able to do together and where you have seen the positives and the movement. And you've been able to achieve so much, and you're in such a different place than you were when I first met you, which is really great. And I know that you're going to continue that.
Great, thank you very much. Well, thank you very much,
Sure.
Dan. We got a few more questions that I'm just going to send you by email as we're
Okay.
running over time, and I just would like to thank everyone for participating in this webinar. And again, the video recording of the webinar is going to be made available on the NOFAS website at www.nofas.org within 24 hours of the conclusion of the webinar. So if you'd like to watch that video, and look at the slides again, or if there's anybody else that wasn't able to make it to the webinar that you'd like to let them know that that is going to be available. And when you're on the NOFAS website, you can get a lot of resources from NOFAS there as well. We have a resource directory, state-by-state resource directory of resources for individuals and families living with FASD, and a lot of information, frequently asked questions, and that sort of thing. You can connect with NOFAS on social media. We have a very vibrant, active Facebook community, as well as Twitter. You can find that information on the NOFAS website, and connect with NOFAS on social media for all sorts of information on FASD community news, research news, updates, that sort of thing. And we have also from NOFAS a weekly roundup email newsletter that you can subscribe to. You can go to the website nofas.org and click on the link for the NOFAS weekly roundup, and that comes once a week on Mondays. It has a lot of information on the latest FASD research and community news, information, resources, that sort of thing, so you can sign up for that as well. So I'd like to thank Dan very much again, and I'll just turn it back over to you, Dan, if you'd like to have any concluding remarks.
Yeah, again, I would just reiterate what Andy just said and thank all of you for participating and being interested in this field, whatever your role is in this field, and doing what you do. And that, you know, I really want everybody to know that whatever you are doing involving FASD, as I said, can absolutely save people's lives, and you are all really vital in addressing this and really helping move this field forward. And we have to get the word out about both prevention and intervention in FASD, and make many more people aware of the impact of this in individuals' lives, and also that, again, this is not, you know, willful behavior on the part of women or men. This is not a willful issue. So we have to break through that stigma as well. So thank all of you, and again, I want to thank the FASD Center for Excellence and NOFAS for allowing me to do this.
Great. Thank you very much, Dan. Thank you.